We'll try to have the discussion at the end or after every talk. What do you think?
Good evening, Dr. Shantanu.
Hi, Dr. Sunil. How are you?
Yeah, I am good. How are you?
All good, all good.
I think you are busy with the Echo India work.
No, it's all done, man. I was busy in the
great,
hospital
great.
with something. Yeah.
Okay.
So, Mansi, we and do the. Hi, good evening, sir. Dr.
Good
Lagesh.
evening. Good evening.
Good evening. Dr. Aniruddha, good evening.
Shantanu is there.
Yeah, I'm there. Yeah, I'll be there.
Aniruddha is searching for you, I think.
Yeah. So, Dr. Mansi, we'll take the questions later, or what do you want to do?
Sir, after each session, we can take the questions.
Let's do that. Perfect. Yeah.
We are already having the questions. The audience are already asking the questions. So
Yeah.
after relevant talk, we can have the questions.
Absolutely great. Perfect.
So this will be the flow.
Right.
So the session will begin with your context setting. After that, we have the first session by Dr. Sunil Bohra sir. Second speaker will be Alagesan sir, followed by Dr. Mittal sir, and last will be Dr. Aniruddha sir.
Perfect. Sounds
After
good.
each session, we would like to take the question and answer. And like last time, we would like to take the poll from the audience, and we can project the results at the end.
That's great. Perfect.
Yeah.
Dr. Allegation, I got your email.
Okay.
Yeah, I think sounds good. So we are having the PNDT in the hotel. So
Okay.
so the live workshop will be with patient in the hotel.
With the patients?
Yes.
Oh, I see. That's good.
Yeah.
Long time since we had patients in the conference. Because nowadays they were not allowing and all that.
No, so Dr. Manjuran and Dr. James have tried really hard. So they have got it. So because that's what the delegates want. If they can live, that will be
that
great.
will keep the conference actually interested and interesting, and to see the patients with the patients. Even though we show a number of cases from the laptop, it's nothing like seeing the patient live. So,
correct. And if you see this time, I have kept a lot of time for discussion.
Okay.
So that's because it's important that we encourage some questions and we encourage some discussion. So that's important. Yeah. Dr. Aniruddha, you got your invite? Correct?
Yeah. I got you the mail. Everything is okay. So no problem.
Dr. Sunil, did you get it?
Only thing is that my workshop, you have seen the hemodynamic and focus.
Right.
You have given. So that is a live workshop will be a little difficult. I think.
So I think I will send. There will be another email, but I think now we are at 2 minutes. And Dr. Sunil, I think you will soon get it. I think
I got the mail, but then I had a query. Anyhow, I don't want to take it up now. I'll just email it later. No problem. I'll reply to that.
Perfect. Yeah.
I had some confusion. Means it was not very clear to me. So I'll get back. That's not.
That's great. That's great. Perfect. Right. Okay. Great. So you're going to give me a countdown, Dr. Mansi?
Yes, sir. Our technical team will give me the countdown.
Perfect.
So I will introduce all of you. Then, sir, I will hand it over session to you for context setting. Yeah. Technical team, please give me the countdown.
Sure. We have 1 more minute now.
Yeah.
How many persons are there in the other room? In the audience room?
Raksha, can you please confirm?
Sorry, Dr. Mansi, come again.
So sir is asking how many audience they have joined.
So we will
Just
check
one second
on the number, sir. So in the meanwhile, sir, we are about to go live. Tech team, can you give us a countdown of 10 seconds, please, before going live?
Yeah, sure.
Thank you.
So currently we have 700 plus who are waiting in the backend.
Okay.
Last time we had almost around 1300, 1400, I remember.
Yes.
And some other will be joining, I think.
Correct.
Technical team, my slides are visible?
Yes, visible.
And moving, right?
Yes, moving. We have 5 more seconds to go live. Yes, we are live. We can start.
So good evening, everyone. I am Dr. Manasi on behalf of entire Glenmark family. I would like to welcome you for this educational initiative in 2D Co Advanced Technique, which is collaboration with the API. This training program is mainly for the healthcare professionals who are eager to deepen their expertise in 2D Co technique. So we have already covered the first module. We total have the 6 module, and we are initiating the second module today. This will be the agenda. After introduction, our moderator, Dr. Shane Gupta sir, he will have the context setting. Our first session is on a regional wall motion and thickness evaluation. It will be taken by Dr. Sunil Bohra sir. The second session will be taken by Alagesan sir on 2D Co in complications of STEMI. Our third speaker, Dr. Sanjay Mittal sir, he will be talk on a stress echo for IHD. Our last speaker, Dr. Aniruddha sir, he will guide us on the echo for viability assessment. After each session, we are having the question and answer. And at the end, Dr. Shantanu Sengupta sir will give the closing remark. It's my pleasure to introduce today's moderator, Dr. Shantanu Sengupta sir. He's a heart failure specialist at Sengupta Hospital and Research Institute, Nagpur. Sir is having the PhD in HFpEF from Newcastle, UK. Sir is the Associate Director at Cardiovascular Ultrasound and President-elect for Indian Academy of Echocardiography. Sir is the editorial board member for Journal of American Society of Electrocardiography. Similarly, he is a reviewer of multiple international and national journals. He is a program director for Echo Nagpur. He was a past president for CSI for Vidarbha chapter, and he was a past president for Diabetic Association of India, Vidarbha chapter. He was the first cardiologist from India to present at the late-breaking trial at ACC 23, and his mainly area of interest and his work is recognized nationally and internationally for the heart failure research and echocardiography education. Moving to the speaker, there is Dr. Sunil Bohra, sir. There is a senior consultant at internal medicine, diabetology and non-invasive cardiology at Apollo Multispeciality Hospital, Bangalore. Sir is a vice president at Indian Academy of Electrocardiography, Karnataka chapter. Sir is associated with the different scientific organizations such as API, RSSDI, Karnataka chapter of RSSDI, Indian Academy of Electrocardiography, CSI, and Royal College of Physicians of the Edinburgh. Sir is having the fellowship of IAE, Eco India. Sir is a reviewer of the international and national medical journal, and he is having publications in many reputed journals. There is some technical problem from my friends. Yeah. Our next speaker, Dr. Alagesan sir. Dr. Alagesan sir, he's a professor at the MGR University, Chennai. He was a retired professor at the head of department at Madras Medical College. Sir was a past president at Indian Academy of Echocardiography. He was a past president at Tamil Nadu chapter of CSI. Moving to the next slide, our next speaker, Dr. Sanjay Mittal sir. Sir is a vice president. Sir is a vice president at Clinical and Preventive Cardiology at Research at Medanta Hospital. Sir is a vice president at Indian Academy of Electrocardiography. Similarly, sir is a member of European Society of Cardiology, Heart Failure Association, Heart Failure, American Society of Echocardiography, CSI of India, Heart Failure Society of America, etc. Sir is awarded with the prestigious CME Excellence Award, Appreciation Award, and Best Echocardiography Publication Award, sorry, Workshop Award. Our last speaker, Dr. Aniruddha De, is a consultant at non-invasive cardiologist at Suraksha Diagnostic, Kolkata. I'm extremely sorry, sir, for the disturbance. Last speaker, Dr. Aniruddha Dey, sir. He's a consultant and non-invasive cardiologist at Suraksha Diagnostic Center, Kolkata. He was a former consultant at Apollo Multispeciality Hospital, Kolkata. He's a life member of CSI India and life member for Indian Academy of Echocardiography. I'm requesting Dr. Shantanu Sengupta, sir, for context setting. I'm extremely sorry for the technical problem. Over to you, sir.
Thank you, Dr. Manti, for the nice introduction. So I think this is the second module, and this is an effort to tell everyone about the importance of echo. And today is an important chapter on ischemic heart disease, and we are having all the important speakers. So without wasting time, if I can request Dr. Sunil Bohra to start his lecture on assessment of regional wall motion abnormality in a patient by echo. Sunil, please.
Sure, sir. I'll just share my slides.
Visible, yeah.
Okay, great. So good evening, everyone. It's a pleasure to be here talking about ischemic heart disease, and I, being the open batsman, we'll speak about the regional wall motion abnormality and the thickness evaluation. How do we do by echocardiogram? So detection of regional wall motion abnormality is integral to the evaluation of LV function in any patient, be it a ischemic heart disease patient or any other reason why the patient has come to the echo room for evaluation. And mind you, the analysis of regional wall motion abnormality is characterized by considerable inter-observer variability even when using high-quality imaging modalities. So this is what we have to be in mind, and our aim is to improve this and reduce the inter-observer variability by following set rules and methods of evaluation of the wall motion abnormalities. So what is regional wall motion abnormality? It's basically we are looking at just a second. So we are just basically looking at the endocardial motion and the systolic thickening of the muscle. So this both the things are very integral to identifying and observe and describing what wall motion abnormality has to be looked at. And when we are looking at the regional wall motion abnormality as such, it is influenced by various factors. The first one is the regional flow, which again hampers or influences the regional thickening. So whenever we are looking at, in this example, this I have given a normal echo along with an abnormal echo. So here you can differentiate what I meaning. So and then tethering or the hyperkinetic effect also influences. So when you're looking at the tethering effect, it is the pull of the abnormal myocardium by the normal myocardium, so which influences. For example, here if you're seeing there is a hypokinetic segment here, but then because of the tethering effect, it looks more that it is moving much more than what it has to. Again, the cardiac translation and rotation during systole again plays a very, very important role, and the cardiac motion during respiration and other loading conditions also have to be kept in mind when we are looking at the wall motion abnormality and defining them. So this is the place where the inter-observer variability also kicks in. So what is the cause, most common cause of regional wall motion abnormality? Obviously, it is the coronary artery disease. So we should know the coronary anatomy. I'm sure all of us know this. I don't want to go into the details. So the right coronary, left coronary, and then the left anterior descending left circumflex artery, we should know. And side by side, we also should know the ischemic cascade. So this is very, very important where we catch the patient in evaluating for ischemic heart disease. Suppose we want to evaluate a patient earlier. So my next speakers will be speaking about the perfusion abnormalities, the strain imaging, all those things. And then when the patient comes actually with the angina, he would have gone through this, so we would have missed capturing the patient in these things. So when we do an echo, we look at the wall motion abnormality, but then there are various modalities now available wherein we can identify the patient before he actually lands up with angina or a scar. So we should know the LV segmentation. This is very, very important to know to describe the wall motion abnormality. So we should know in all the views. I'm sure all of you know the views by now. So we look at the 4-chamber, 2-chamber, and the 3-chamber view, and also the short axis views at the basal level, the mid level, and the apex. And the wall motion, definitely we need to be aware of the segments. So I'll not go into the details. I think it should have been covered in the first module. So the left ventricular segmentation according to the ASE is divided into the 17 segment model. So we have the 6 basal segments, the 6 mid segments, the 4 apical segments, and then the apical cap, what is mentioned here. And definitely you should know the arterial distribution so that you can correlate with your ischemic territory and correlate with your findings. So once we know this, we come to the actual topic of how to assess the regional wall motion abnormality. So the first basic rule is to look at as many views as much as possible, and you should not depend only on 1 or 2 views to define the wall motion abnormality. So you have to look at the various views which are available and identify the wall motion abnormality, describe them in each segments wherever the wall motion abnormality, and then come to a final conclusion. So once we have done that, so how do we know, how do we evaluate the wall motion? So the ventricular segments are actually analyzed based on the following methods. So one is the qualitative method, which is basically we look at the wall movement and the wall thickening. And the most easiest or the most commonly used is the eyeball assessment. So wherein we describe the normal hypokinetic, akinetic or dyskinetic segments, and also look at the presence of scar or aneurysm, which I will tell in the next few slides how to assess this. The second one is semi-quantitative method, which is including the wall motion score or the score index, and the quantitative methods. The quantitative methods are the fractional shortening or radial shortening, which we look at the fractional area, cavity area change, the caudal central line analysis, and the Doppler tissue-based, that is the tissue Doppler and the strain imaging and the torsion, what we look at. So coming to each one, how do we grade the regional wall motion abnormality? Again, so define what is normokinesia is when we look at the wall thickening in systole. If it is more than 35 to 40%, then that is normal. So if it is 10 to 30% of the original length, then it is hypokinesia. If there is less than 10% or no inward movement, then we call that segment has to be akinesia. And if it is moving outwards as compared to the other segments, that is called as dyskinesia. And aneurysm is bulging outward, and also in diastole is aneurysm. And then each one we give a score of 1 to 5 based on the description of the segmental motion. So once we do this, I'll go one by one how to analyze the wall motion. So the first one is the qualitative method, the eyeball assessment. This comes with experience. So we just look at all the segments, whatever is possible in all the views, and then look at whether it is normokinetic, hypokinetic, akinetic, or dyskinetic. So here, this is normal, what we're saying. I've given 3 examples here. The normal wall motion, what is happening here? So more than 30 to 50% of the thickening is appearing as compared to this patient wherein there is almost akinesia of the segment. There is hardly any thickening or less than 30%. And this segment is the aneurysm segment wherein it is actually moving away from these basal segments. So, and then when we look at the presence of the scar, so there is a scar here, and then you can see this dyskinetic. And if there is an aneurysm formation, we can easily define this. But this is a qualitative method, and it can have inter-observer variability. So moving ahead, we can go to the semi-quantitative methods, which is the wall motion score index. So how do we do this? Again, we look at the scoring, and then each segment, we look at the each view, and then we define each segment, and we have to look at whether it's a normokinetic segment, a normokinesia is there, or there is akinesia or hypokinesia or dyskinesia. And depending on that, we label this, and we add sum of all the wall motion scores to each segment, and then divide by the number of ventricular segments which we have observed. And that gives a score, and that will tell us what is the severity of the wall motion on per se. So next is the quantitative method. Here there are a few methods which are available, and these are more as this one says, it is quantitative. So we are quantifying what is the wall motion happening. So here we look at the fractional shortening, which is calculated by the diameter during systole, and we give the value. So if it is more than 28, it's 28%, it's considered normal. So we are looking at the left ventricular end diastolic dimension and the end systolic dimension, and then we are giving a number here. The next one is the fractional cavity area change. So here again we are looking at we trace the LV cavity along the endocardial border, excluding the papillary muscles in both diastole and systole, and then we can calculate the fractional area change by the formula LV end diastolic area minus the LV end systolic area divided by the LV end diastolic area, and a normal value is anything more than 35%. So when we are looking at this, so this is basically the eyeballing which we are doing. So if the fractional cavity area change is good, suppose for example it is 60%, then that means there is normal. Again, it correlates with the EF. And as the fractional cavity area changes, the LV dysfunction or the severity of the LV dysfunction is more. So this is the quantitative way of doing. So the next quantitative way of doing is looking at the myocardial velocity. So here we basically use the tissue Doppler method, and we look at how the annulus is displaced towards the apex, and then we measure the velocity, and we can quantify the wall motion according to the velocity of the myocardial motion. So here we look at the annular movement in all the views we can see in 4-chamber, 2-chamber, 3-chamber, and then we can quantify. So the next method is the strain or the strain rate imaging. The strain, it measures tissue deformation, and it's defined as a change in the initial length, which is normalized to the change in the length normalized to the original length, and the change, the difference, we give it give a number. So here basically we are looking at how much change is there, and this gives a regional function, regional motion abnormality, and then this is a quantifiable method wherein we give a number. So anything more than minus 20 is considered normal. So, and then we can look at the rate of change of this change in the myocardial movement, and you can give a number, and these are all quantitative methods. So for that, to know the wall motion abnormality, we should know the myocardial mechanics. So for that, definitely the muscle orientation is very, very important. So what is the orientation of the muscles in the subendocardium and the epicardium? So from the right helix, it moves to the left helix in the epicardium, and in the middle, it is basically the circumferential muscle. So based on this, the strain imaging is looked at. So the myocardial mechanics per se, there are three mechanics: longitudinal mechanics, wherein the movement of the base to the apex we are looking at; the circumferential mechanics, so in the circumference, how much is the change we are looking at; and the radial mechanics, so the thickening of the muscle, basically the circumferential fibers we are looking at. So this again we do day in and out by looking at the MO, the thickness. So we can easily calculate the radial movement of the myocardium. And to per se, to add to everything, then we look at the rotation and the twist mechanics, and this is like this ringing of the trowel which we do, that increases the ejection fraction, and overall the whole mechanics has to be looked at, and the net effect is the ejection fraction what we calculate. So basically in speckle tracking echo or strain imaging, what we are looking at, the individual myocardial speckles which we are seeing, and then we are looking at the machine tracks the movement of these speckles, and it will give a number in the form of strain imaging. So to for the people who are not doing strain imaging, it is very, very important how to acquire the image so that you don't get anything like abnormal values. So to know how to do strain imaging is also very important. So it helps us to give meaningful numbers. So for that, you should know how to optimize your machine. Though the newer machines have all auto calculation, but then the basic thing is you should have a good machine setup. You should have a high frame rate of almost at 40 to 80 frames per second. The image has to be optimized. We have to look at the focus position, keep optimal sector depth and width, and avoid artifacts. And obviously, we should have an ECG gated image recording. So basically, we require 4 views, though the newer modalities they can do with lesser views also. But then these are the basic views which we are looking at: the 3-chamber view, the 2-chamber, the 4-chamber view, and the short axis. And then once we acquire this, we can calculate the strain, the global longitudinal strain, and it gives us a number. So anything 18 to 20% is considered normal. And when we look at the abnormal, the bull's eye plot, so everything should look red. And these are the individual segmental strains which are displayed here, and it will give us a overall strain or the global longitudinal strain also. So this is how the global longitudinal strain will read, and anything above 18 to 20% is considered normal. So this is an abnormal example wherein you see the strain is not normal. There is reduced strain in this LAD territory, and the global strain is also reduced to 10%, which means there is LV dysfunction. And when you look at the bullseye plot, it will give us a fair idea of which territory, which artery is involved, and based on this, you can quantify your wall motion abnormality also. So this is another example, the right coronary artery. I'll go very quickly here. So these are the segments which are affected. The inferior and the posterior wall is affected. So this is how you know. So we had published a paper when we looked at the strain imaging to assess the global and the regional left ventricular function in acute myocardial infarction. And then we had a good correlation wherein in ACS patients who were undergoing PCI, it was a good predictor of the short term and the long term outcome, and useful for analyzing the regional and the global LV function. So having said all these things, there are few limitations of regional wall motion wall assessment. So it depends basically on the image quality, the endocardial border definition, the angulation of the transducer during acquisition of the short axis views is very, very important, because you need to have the image perpendicular to the long axis of the LV. And obviously the translational and rotational movements of the heart during cardiac cycle play a very, very important role. And Valsalva manner also can affect the wall motion analysis. Apart from the ischemic causes, we should be aware of the non-ischemic causes of the wall motion abnormality, basically the conduction system abnormalities like left ventral branch block or ventricular pacing or frequent ventricular ectopics. They all can affect abnormal septal motions in the form of right ventricular volume and pressure overload or pericardial constriction also can affect post-cardiac surgery patients, and other congenital problems can affect the wall motion abnormality, and we need to be aware of these causes. So what are the limitations of the regional wall motion abnormality? Again, as many studies have shown that almost 20% in 20% of patients, the endocardial border definition is suboptimal, wherein we are not able to see the segments. And though this has been overcome by the advent of the tissue harmonic by harmonic imaging, but then again, in few cases, it will be difficult. And when tethering is there, it can affect the wall motion abnormality analysis. So what are the various ways to improve the detection of wall motion abnormality? Again, probe selection is very, very important to improve the image resolution, the temporal resolution, and we need to use the harmonic imaging so that we can get good optimal images. So once we have done that, we need to optimize the image by using the various methods. So one of the most important method is contrast echocardiography. You should never hesitate to use this whenever your image is suboptimal. And these are the limitations of regular echocardiogram. And then we can improve that by using the contrast agents. So there are intravenous agents which are available, which are useful for LV opacification. And these are commercially available, and they are heavy gases which are high molecular weight agents which are used. Most commonly the sulfur hexa fluoride agents which are used with a lipid core which avoids destruction of the bubbles, and it passes through the pulmonary circulation and comes to the left side of the heart, which helps in opacification of the LV. So here in this patient, for example, here we are not able to see the segments very clearly, and then when we give a contrast, we will be able to see the LV myocardial segments properly. Along with that, we can even pick up the subtle LV thrombus which is there in this patient. So again, it is very, very useful to define the wall motion, the segments basically. So again, I'll skip this. I think Dr. Mittal will be speaking over the stress echo. So I'll just skip this and then go to the end. So to summarize my talk, the methods to improve the detection of wall motion abnormality in routine clinical practice, we should have a good knowledge of the ischemic heart disease, which is very, very important. We should be aware of the non-ischemic causes of the wall motion abnormalities. Appropriate probe selection and optimization of the 2D image is very, very important to analyze so that we can reduce the inter-observer variability. Use of harmonic imaging is recommended. Use of LV contrast classification to improve the endocardial border definition is very, very important, and we should have a low threshold to use this. semi-quantitative and quantitative analysis of wall motion abnormality has always to be aimed at, so that the inter-observed variability again reduces. Whenever possible, and nowadays most of the machines have strain imaging, so make use of it, especially in specific indications, say for example, wall motion abnormality in a patient whom you are following up regularly, or chemotherapy, or cancer patient who is on chemotherapy, cardiomyopathy patients. Again, this is very, very important. Stress echo is there. Dr. Mittal will be speaking. So I'll end here, and I can take some questions.
Thank you, Sunil. Very nice talk. Can stop the screen share.
Yeah.
There are a few questions. Let's take it right away. Okay, so what are the key echo parameters to differentiate viable from non-viable myocardium based on regional wall motion? I think I've already told, but you can again.
Can you come back? I did not hear that.
What are the key echo parameters to differentiate viable from non-viable myocardium based on regional wall motion?
Yeah, so again, you have to look at the wall thickness. So if the wall thickness is maintained, then that means there is some viability. As against a patient whose segments are akinetic or dyskinetic, that means the myocardial segments are not viable. And then there is some role of strain imaging, wherein you can look at the strain values, and that will also give. And the most important thing is to look at the dobutamine stress echo. So I think that Dr. Mittal will be going to speak. I leave it to him.
Right. How does wall thinning correlate with myocardial viability in chronic ischemic heart disease?
The same thing. So if there is a scar tissue, that means it's already dead. And if it is hypokinetic, suppose the thickening is about 20 to 30% thickening is there, that means it is viable. And the assessment again will depend on how you take up the viability assessment, which again the next speaker is going to speak. So I think I'll leave it there, so that it will be taken care by the next speakers.
What are the limitations of visual wall motion analysis, and how can they be mitigated in practice?
Yeah, that I have covered in my talk. So you have to use the semi-quantitative method. And again, I would insist or emphasize that using contrast agents is definitely helpful to improve the wall motion analysis.
Right. So I think the focus has been that good assessment of the regional wall motion is important. And let me emphasize that we still see an M-mode usage in many of the ejection fraction that should be avoided. And I think biplane Simpson with regional wall assessment is the key. So I think thank you, Sunil, for a nice comprehensive talk on this important subject. So let me now request the next speaker, Dr. Alagesan, if you can share your screen, please. Yeah, your slides are visible.
And go back to that's okay.
Yeah.
Shall I go ahead?
Please start, sir.
Okay. Next 15 minutes, I will try to show as much images as possible of the complications of acute myocardial infarction. This is a preliminary slide. If the coronary artery is occluded for 5 minutes, usually the wall motion abnormalities happen during ischemia and they recover within 1 to 2 minutes. When there is an occlusion of the artery for about 30 to 120 minutes, then the wall motion persists for usually to 48 to 72 hours. Sometimes the recovery may be delayed for weeks or more, weeks to months. If there is a fixed wall motion abnormality, usually indicates the patient has gone in for an acute myocardial infarction, or sometimes it may happen due to repeated stunning or hibernation, etc. After a myocardial infarction, there is a period within 20 to 48 hours, there is thinning of the transmural infarcted segment without scar formation. There is no collagen tissue formation. So the muscle itself is thinned out, and this forms the substrate for development of the ventricular septal rupture, free wall rupture, and papillary muscle rupture. After, say, 48 hours, from 3 days to 6 weeks, usually the thinning and scar formation occurs. The myocardium is replaced by fibrous tissue. So the incidence of rupture is going to be less. And in the chronic stage of the ischemic heart disease. There can be infarct expansion, aneurysm formation, and the ejection fraction is decreased. It can go in for an ischemic cardiomyopathy and cardiac failure. These are the complications of myocardial infarction. One of the most important complication is death. So during the pre-CCU era, it was 30%, and the CCU era, it was reduced to 13 to 15%. With the reperfusion therapy with thrombolytics and PCI, it has been reduced to 5 to 7%. But this 5 to 7% is very difficult to reduce because of one important complication, which is shock. Shock is defined as a BP less than 90 millimeters of mercury for at least 30 minutes, not improved with fluid administration, signs of hypoperfusion, cold extremities, and altered mental status, restlessness, agitation, reduced urine output, and reduced cardiac index. So this is one of the important complications which can detect the complication and prevent this, help in preventing this complication. If you take shock, you can see the left ventricular function deterioration is the most common cause of the shock. 78% of the patient, it is due to left ventricular dysfunction producing reduced ejection fraction. In other patients, some other patients may be due to ventricular septal rupture, mitral regurgitation, RV infarction, tamponade, etc. If you see the patients who are coming to the ICU, only 1% of the patients have, shock when they are presenting in the ICU itself. The rest 66.2% of the patients who are coming to the ICU with myocardial infarction develop the shock after 24 to 48 hours and up to even some few days. So can echo pick up those patients who are likely to go in for a shock? This is a patient with anterior wall myocardial infarction. The wall motion abnormalities in this patient, you can see the interventricular septum is hypokinetic, and actually the lower portion of the interventricular septum is akinetic. In the apical four-chamber view, you can clearly identify the lower two-thirds of the interventricular septum at the left ventricular anterior wall is akinetic. But to compensate for that, you can see the left ventricular posterior wall is contracting well. Whenever you see an infarcted segment with hypercontractile motion of the left ventricular other segments of the myocardium, then it's a good sign that patient is going to do well and the patient will not develop any, shock. This is another patient, an anterior wall myocardial infarction in a patient with inferior wall myocardial infarction. You can see this inferior wall is completely akinetic. There is again akinetic contraction of the lower two-thirds of the IVS and LV apex. There is a large clot in the left ventricular apex. So this patient, you have to be very careful. If the patient comes early for a PCI, then we have to do a PCI to avoid the myocardial damage, or at least give thrombolytic therapy to prevent the myocardium and save the myocardium, so that the patient will be prevented from going in for shock. This is another patient where there is completely akinetic, thinned out myocardium. The ejection fraction was 16%. This patient has significant mitral regurgitation also. And this patient had a type 3 diastolic dysfunction. So these three are indicators that the patient may go in for a shock, or the patient may be presenting with a shock. Ejection fraction of less than 28%, 2 or more degrees of mitral regurgitation, and type 3 diastolic dysfunction or the restrictive pattern. These patients, you have to treat them vigorously, do PCI, give a thrombolytic therapy, and carefully treat the patient and prevent shock. The next common cause of shock is right ventricular myocardial infarction in inferior wall infarction, even associated with inferior wall infarction. This is a patient with inferior wall myocardial infarction. You can see the left ventricular hypertrophy in this patient. The left ventricular function itself is only mildly or moderately depressed. But you can see there are wall motion abnormalities happening over the right ventricular anterior wall. You can see the hyperkinetic motion of the left ventricular apex. This is called the McConnell sign. And the patient has got significant tricuspid regurgitation. The liver is enlarged. The IVC hepatic veins are dilated. I'll show you the liver is enlarged, the IVC and hepatic veins are dilated, absent respiratory variation. So this patient has got a right ventricular infarction associated with inferior wall infarction. This patient, you should be careful to treat them with adequate fluids and not give the diuretics and lower the volume. It is better to give a little more fluids in these patients with inferior wall infarction, with RV infarction. One of the things which can be used is for identifying the inferior wall, right ventricular infarction is the tissue Doppler from the tricuspid annulus. You can assess the right ventricular function by different methods, by the TAPC, by say right ventricular strain, etc. The other mechanical complication which occurs during the acute period is ventricular septal rupture, papillary muscle rupture, free wall rupture, and dynamic outflow obstruction. Usually, when the LAD is impacted, LAD territory, it produces a ventricular septal rupture near the say in the lower 1/3 of the interventricular septum. You can see the left ventricular function is good in this patient, but there is a defect in the interventricular septum in the lower 1/3 with the color flow showing clearly left to right. And this is the velocity across the ventricular septal rupture. And this can be clearly visualized in the 3-dimensional echocardiogram. You have oval defect in the lower 1/3 of the interventricular septum. This is another patient with an inferior wall myocardial infarction. There is wall motion abnormality of the inferior wall and inferior septum. And color Doppler clearly shows left to right shunt across the inferior septum. So this is a patient with inferior wall myocardial infarction with ventricular septal rupture. And you can, the 3-dimensional echocardiogram, there is a defect in the lower 1/3 of the, in the inferior portion of the interventricular septum, and color Doppler shows left to right shunt. 3-dimensional color Doppler echocardiography shows the left to right shunt across the ventricular septal rupture. This is another patient with inferior wall myocardial infarction where there is an aneurysmal bulging of the inferior septum. So there is an aneurysm of the inferior septum because of the myocardial infarction, and with the color Doppler, you can see multiple jets along the say from the aneurysm. So this is a patient with inferior wall infarct. Inferior septum is impacted, and it is bulging into the RV, producing an aneurysm, and there is a ventricular septal rupture. And this patient was operated in our general hospital, and the patient has done well. There is one surgeon who takes up all these difficult cases, though there is still a residual shunt, but the patient survived this residual shunt and the patient went off well. The next complication is the free wall rupture. So the most common one is a slit-like tear. So when the patient is admitted for myocardial infarction, he suddenly develops a chest pain, there is a fall in BP, there is an electromechanical dissociation, and the patient dies. The free wall rupture can be sometimes subacute. So due to localized necrosis of myocardium, and sometimes the patient may survive and may be able to operate. The third one is myocardial thinning and rupture in the center. And this late ruptures especially occurs in patients with multivessel disease. This is a patient with anterior wall myocardial infarction. You can see a clear dropout in the left ventricular anterior wall. And there is a small pericardial collection of fluid. This patient actually survived in spite of the free wall rupture. And this patient again was operated by a surgeon. Even though the left ventricular function is very poor, you can see the left ventricle, the pericardial collection has decreased, and he was able to patch the free wall rupture and save the patient from sudden death. This is another patient with inferior wall myocardial infarction. You can see that there is a small defect in the inferior wall, which is akinetic, and there is a left to right shunt across the inferior wall. There is a to and fro flow from the left ventricle into this pericardial space where the blood has leaked. So this is a patient with inferior wall infarct with rupture of the free wall. A dynamic left ventricular obstruction especially can happen in patients with systemic hypertension and myocardial infarction. So this is a patient with marked left ventricular hypertrophy. You can see akinetic contraction of the lower two-thirds of the interventricular septum. In these patients, if you give energetic diuretics, then it may result in a systolic anterior motion of the anterior mitral leaflet and produce left ventricular outflow obstruction. This may be mistaken for, say, hypotension, and say if you don't recognize this complication, you may try to give the patient, say, infuse dobutamine or dopamine, and this will further aggravate the left ventricular outflow obstruction. So this is the one on, when we saw the patient first, and then there was a left ventricular obstruction which was recognized by echocardiography. Then fluids were given, and the patient was started on beta blocker, and the left ventricular outflow obstruction was relieved by giving fluids and left ventricular beta blocker. The chronic complications is, one of the chronic complications is the true aneurysm, or when it ruptures into the pericardial space, it can produce a pseudoaneurysm. So this is a patient with a large anterior wall infarct. You can see a large aneurysm which is visible even in the X-ray chest, PA and lateral view, and you can see the calcified pericardium with the aneurysm of the left ventricle. Usually, the true aneurysm has a large mouth, whereas a true pseudoaneurysm usually has a narrow mouth. This is another patient with aneurysm, but in this case, there is a rupture of the left ventricular posterior wall, inferior wall. Here there is a large rupture, you can clearly visualize, and this is a collection which has occurred in the pericardial cavity, and you can see clot formation also. So this is an inferior wall infarction with free wall rupture producing a pseudoaneurysm and a thrombus also. There is another patient with free wall rupture happening in the lateral wall. In this, this is again inferior wall. We'll skip this one. And this is the one which a free wall rupture in the lateral wall. You can see in this view, the contraction looks almost normal. But when you go to the fourth chamber view, you can see a large defect in the, in this lateral wall. And there is a large collection of blood inside the pericardial cavity. So this pseudoaneurysms are likely to rupture. So these patients should be taken up for surgery earlier. So whereas a true aneurysm very rarely ruptures. The other important complication is mitral regurgitation. Mitral regurgitation is seen more commonly in patients with inferior wall infarct. This is a patient with inferior wall infarction. And usually it is due to the tethering of the posterior mitral leaflet, and the anterior mitral leaflet co-opts down into the posterior mitral leaflet. The jet is directed posteriorly. You can see the jet is directed posteriorly. So in inferior wall infarction is commonly associated with mitral regurgitation even in the acute stage, and more often it is due to tethering of the posterior mitral leaflet. Whereas in anterior wall infarct, during the acute period, mitral regurgitation is usually uncommon. This is a patient with mild mitral regurgitation, and this is after, say, remodeling. After 4 to 6 weeks, there is remodeling of the left ventricle, which leads to, again, the mal cooptation of the anterior and posterior leaflet, and there is stenting of the anterior and posterior leaflets, and the mitral regurgitation is usually in the center. When it occurs due to remodeling and mal cooptation due to tethering of the anterior and also posterior mitral leaflet, it produces a central jet. The other complication is a papillary muscle rupture. The papillary muscle rupture can be a complete rupture, it can be an incomplete rupture, or a partial rupture. So this is a patient with a papillary muscle rupture during the acute myocardial infarction. You can see the ruptured end of the papillary muscle as a mass here. And there is a severe mitral regurgitation. This is a mass of tissues, papillary muscle tissue, which is visualized inside the left atrium. And usually these patients, the blood pressure is low. Usually we cannot hear the murmur. Whenever there is a sudden fall in blood pressure, we have to do a echocardiogram. And for a papular muscle rupture, it is better visualized by the transesophageal echocardiogram. This is one of the cases seen in Madurai, and one of our postgraduates who is working there sent me this image. LV thrombus occurs commonly in about 4 to 7% of the patients. It's usually small and usually resolved by itself. Most of the time, we don't even diagnose the thing. Sometimes there can be layered thrombus like this near the left ventricular apex. This is a patient with anterior wall infarction with a layered thrombus, and you can visualize the thrombus even in the 3-dimensional echocardiogram. This is another patient with a large thrombus, little mobile. So this is a patient actually came with the gangrene of the, say, one of the fingers. This patient has a large thrombus and it is partially mobile, and patient already had the embolic episode. So we were actually worried. So we did the coronary angiogram and sent the patient for surgery. So one of the surgeon does a repair of the left ventricle by something like a DAR procedure. He puts a patch and reshapes the left ventricular apex. So he has put a patch and excluded the left ventricular thrombus, and then the left ventricular function also has improved in this patient. So this is a echo after the surgery. This is another complication which can occur when there is a oozing of the blood into the myocardium itself. Then it produces a layered appearance like this, which is mobile. This is called intramural hematoma. This is again is due to a partial rupture of the myocardium itself. So this can be identified by echocardiogram. If there is any doubt, we can do a MRI which can differentiate between true thrombus and the intramural hematoma. This again is very prone for rupture. So this patient should be operated. If you see a picture like this indicating intramural hematoma. This is the apical long axis view. This is the color flow, which shows the thing. The take-home message is to assess and to diagnose myocardial infarction, to assess systolic and diastolic function and risk stratification. Echo is extremely useful. To rule out other causes of chest pain like pulmonary embolism, dissection of aorta, pericardial tamponade, etc., again, echo is extremely useful. There are certain conditions, other conditions which produces ST elevation in the echocardiogram apart from myocardial infarction. For diagnosing these conditions, it is very useful. And for diagnosing shock during the pre-shock period by assessing the left ventricular, right ventricular function, MR severity, and diastolic function, echo is extremely useful. To assess the effect of treatment, thrombolytic treatment or other types of treatment, again, echo is extremely useful. Echo, in a patient with anterior wall infarction, it can give you the severity of the LV dysfunction, mitral regurgitation, etc. In patients with right ventricular myocardial infarction, it can assess the right ventricular systolic dysfunction, and also you can say it can give information about the atrial infarction and AV synchrony, producing complete heart block. Echo is useful in ventricular septal rupture, thrombosis, ischemic cardiomyopathy, and 3-dimensional echocardiography adds more information to the already information which is obtained from 2-dimensional echocardiography and color Doppler echocardiography. Thank you.
Thank you so much, Dr. Alagesian, for so many videos. I mean, he has an array of so many complications. I mean, these are amazing to see all of them. So there are a few questions. So let me start. So this one is, I think, from previous one, but it's important. How to differentiate ischemic hypokinesia from bradycardia and conduction abnormality?
Pardon?
How to differentiate ischemic hypokinesia from bradycardia and conduction abnormality?
This is actually say bradycardia and conduction abnormalities we can identify by the ECG. And if usually in a bradycardia with say if you see the contraction, it will be usually very brisk because the LV is getting filled more during the diastole. So usually we can identify whether the segments are hypokinetic or akinetic, whatever may be the problem. The only other thing, the conduction abnormality, the only conduction abnormality which produces some confusion in the assessment of the wall motion abnormality is left bundle branch block. So in left bundle branch block, there can be some wall motion abnormality involving the anterior interventricular septum, and sometimes there are left ventricular anterior wall. So in those cases, you look at the mid-ventricular and apical segments where the wall motion abnormality can be clearly made out, usually. Only in the basal region, the left ventricular contraction may be abnormal because of the left bundle branch block itself.
Correct. So the next one, what echo signs suggest a high risk of free wall rupture post-STEMI?
During the acute period, usually there is no feature as such which has been described for, say, predicting the free wall rupture. So in any patient with anterior wall infarct or inferior wall infarct, you have to carefully scan the, say, the infarcted region to find out whether there is any thinning, and apply the color and see whether there is any flow from the left ventricle into the pericardium. Even if there is a small collection of pericardial fluid, then you have to be careful. So it may indicate the earliest sign of a free wall rupture. So an impending rupture. So thin walls, infarcted walls with color flow showing some flow into the pericardium, or a localized collection of fluid near the infarcted site, you have to think in terms of a free wall rupture.
Right. So how early can we diagnose papillary muscle dysfunction by echo?
I told you about the two types which occurs. The inferior wall infarction, the mitral regurgitation occurs even early with the acute myocardial infarction itself. This is actually due to tethering of the posterior mitral leaflet by the normally contracting papillary muscle. The papillary muscle should be normal to pull it down and keep it down. So the anterior mitral leaflet co-opts abnormally and produces a mitral regurgitation, and the jet is directed posteriorly. There are cases where, say, when there is a mitral regurgitation, when there is added papillary muscle infarction, the mitral regurgitation disappears because the posterior mitral leaflet is not tethered. So when the papillary muscle should be normally contracting for the tethering to occur. So that is the one which happens in inferior wall infarct. In anterior wall infarct, usually there is no tethering during the acute period. The papillary muscles are usually contracting normally, so the mitral regurgitation is very less. The mitral regurgitation in anterior wall infarction is usually secondary to chronic LV remodeling, which produces the tethering and tenting of the anterior and posterior mitral. Both the mitral leaflet are tethered usually.
What's your first echo modality for suspected post-MI VSD?
Two-dimensional echocardiography. Clearly, it will clearly identify all the cases of ventricular septal rupture. So usually we did not do any transesophageal echocardiography. Whereas for a papillary muscle rupture, you shouldn't believe on the clinical signs of mitral regurgitation. You won't hear a murmur because the blood pressure is low. You will not be able to hear a systolic murmur. Whereas in post-MI VSD, we will be able to hear a good systolic murmur. In papillary muscle rupture, there won't be any, say, murmur and all that you shouldn't be expecting. If a patient suddenly develops hypotension, in those patients, you should do an echo immediately. See whether there is any likelihood of the ventricular septal rupture or papillary muscle rupture. If you are not able to diagnose papillary muscle rupture from the transthoracic echo, you should do the transesophageal echo, which will be diagnostic. Otherwise, we will lose the patient.
Right. The last one, I think you have already answered it, but how distinguishing pseudoaneurysm from true aneurysm by
The only advice which I can give is don't rely on the neck. Usually the neck is small in pseudoaneurysm, it's large in true aneurysm. As I told you, there can be the one wall which is suddenly interrupted. The mouth can be even a large one. So you just see the wall that it will show the rent through which the blood goes into the pericardial space. So in that way, if you take the entire picture, we will be able to easily differentiate between a true aneurysm and a pseudo aneurysm.
Great, sir. Thank you so much, Dr. Legation, for such a comprehensive talk. If I can request Dr. Sanjay Mittal for this next presentation, and a very important topic on stress echo. Dr. Mittal, please.
Thank you, Shantanu, and thank you, Glenmark, for offering this opportunity. I have heard both the topics, and they're very important and probably making my life easier. What I'm going to talk in next 15 minutes is the stress echocardiogram in ischemic heart disease. We have discussed about so many tests available today for the diagnostic armamentarium for ischemic heart disease suspect cases, which is as best as interventionist, intensivist, as well as biochemical. But we are talking about what we can do when we are talking about ischemic heart disease. Well, ischemic heart disease could be asymptomatic, and in asymptomatic stage, we discuss about the ASCVD risk scores. But then one fine day, there would be a person who presents with angina or angina equivalent. These patients could be either acute coronary syndrome or stable coronary syndromes. And obviously, they can either stabilize or turn into acute coronary syndromes where the biomarkers are the mainstay of treatment. But what about a situation when we have a person presenting with angina on effort, and this is predictable angina on effort, and we are not too sure whether this chest pain is of ischemic origin or otherwise? Here is where we talk about stress echocardiogram or stress testing. This is basically directed to first validate the symptoms, second, to diagnose, third, to also add a prognostic value, whether this chest pain is itsy-bitsy stuff or a big one, revascularize or not to revascularize, and also what is going to be improvement in survival. Can we have a prediction there? Simplistically, if I talk about stress testing has two components. One is a stress, and second is a mechanism of testing. So stress could be either a physical exercise, which could be either commonly used treadmill exercise test, or it could be an upright bicycle or supine bicycle ergometer, which is very commonly used specifically when we have to assess in continuum the echo or ECG changes, specifically echo changes, hemodynamic changes. With treadmill, unfortunately, you cannot do that continuously. You have to actually wait and do it only after the exercise stops. The other way is people who cannot walk, they are moribund, maybe have knee injuries or waiting for surgeries. We have to do pharmacological test. And the common one is dobutamine atropine test, where we have to escalate the heart rate and put the heart on stress because of pharmacological agent. Or it could be dipyridamole testing, where it works by actually vasodilating the normal coronary arteries, which leads to, Steele's phenomenon into the diseased coronary segments, very commonly used for perfusion imaging like thallium and all. The way of testing is either we look at symptoms alone, which is what we do in clinical sense, breathlessness and chest pain. The second one is electrical changes. We use as TMT, stress testing, where we do exercise testing and look at the ECG changes. The functional changes, segmental or systolic, global systolic functional changes, which is very commonly used as an assessment of ischemia, marker of ischemia in echocardiogram. Even MOGA and MRI sometimes use that. And the last one is perfusion imaging, which is usually used as perfusion thallium, SPECT thallium, MRI also, and contrast echo. I'm going to deliver on these things a few minutes later from now. And the testing is when we do a certain evaluation at rest and compare the changes which are produced after exercise in these particular fashion. And now I'm talking about stress echocardiogram, where the echocardiographic wall motions, just like Dr. Sunil described, in the baseline are compared to what would happen after exercise when the heart is put to stress. And if we look at all the available technologies compared to stress ECG, the blue line, the green line or the stress MPI is much better, but stress echocardiogram is even much higher in sensitivities of detecting possible coronary ischemia. And specificity also is high, almost to the tune of 77 to 80% in most of the labs of stress echocardiogram. Mind it, here the word is your experience is what matters, because we all know stress echocardiogram is operator dependent. So where do we use stress echocardiogram is firstly to evaluate a possibility of ischemia in presence of coronary artery disease. We know when the blockages are more than 60 to 70%, we would have certain areas of the myocardium reducing in supply and producing wall motion abnormalities where at rest there were none. So this is what it would come out with. We also can associate it with coronary artery disease. Well, we can use stress echocardiogram in certain other indications other than coronary artery disease. I'm not going to dwell on viability testing because this is something which my next speaker, Dr. Anirudh, is going to be talking about. I'm going to be focusing most of the talk in the ischemia assessment discipline only. Valvular heart disease, and sometimes even what we talk about is diastolic stress testing in the evaluation of dubious sources of breathlessness and exertion. We can use stress echocardiogram. Where we should not do stress echocardiogram is when the person presents with acute coronary syndrome, because at that time when his chest pain has been of recent onset and we do stress test, we can actually precipitate a big myocardial infarction. If the person has severe
Hello.
What happened?
I think that there is some technical problem from Dr. Mittal's side.
Yeah.
I
think just let's wait for 30 seconds. Otherwise, we can have the next presenter.
Yes. By the time, technical team, can you please call Dr. Mittal, sir?
I think he's rejoining. I think he must
Okay.
he must have disconnected and rejoining.
Got disconnected. I think let's wait for 30 seconds.
Yes,
Yeah.
he will rejoin.
Yeah, he will surely rejoin. I think these are the side effects of online. Yeah. But by the time, I think if you have any more questions, maybe.
Yes. So there are few
I think
questions I'm posting.
we have taken all the questions till now.
Yeah.
So I can see Dr. Allegation. I mean, I will just have one question to him. By the time we'll wait. Otherwise, we'll go to Dr. Anirudh. So, how to interpret a biphasic response in segments with baseline wall motion abnormality? So, this is for the stress echo. I think let's wait for that talk. Then we'll go ahead. So, Dr. Allegation, would you like to emphasize the importance of ECG gating? Because we still see people doing echo without ECG. It's a very important thing.
So, except in very small kids, usually have a ECG line always always try to have the ECG, especially if we are in the now for timing the events, if we are doing strain echo. So all those things, even though strain can nowadays it can be done even without the ECG. Some machine is having, I think, but you should have a good ECG.
That's very much mandatory.
Yes, the only problem sometimes is it picks up the P wave. So if the P is very tall, sometimes it picks up the P wave and confuses us. But usually, good ECG is a must for when we are doing an echo.
Right. So, could the tech team call Dr. Mittal? Any idea?
Yes,
We are getting in touch. Just, yeah.
I think, should we start with Dr. Aniruddha's talk?
Yeah, I'm ready.
Hey, I think
He's
Sanjay
here,
Mittal
he's
has
here.
joined.
Yes.
I'm so
Sir has
sorry,
joined,
Dr. Aniruddha.
Join.
You're back. Dr. Mittal, you're back.
I'm sorry, but these are Haryana government's regulations that they would not let anything function. So I'm just going to share my slides.
Yeah, please go ahead.
Absolutely sorry about this fiasco, but I'll try to cover it up. Okay. So I'm sorry, I think we had discussed about it that when we have certain things, malignant hypertension, very high blood pressure, or severe left ventricular outflow tract obstruction, we do not do stress echocardiogram. Mind it, there is always a dilemma in the minds of physicians when to opt for TMT and when to opt for stress echocardiogram. At simplistic terms, if the person has ECG which is uninterpretable, that means some changes, some downsloping ST segment or T-wave inversions, we prefer in the resting ECG, if there are changes, to prefer stress echocardiogram. More importantly, if the person has resting wall motion abnormalities, that means previous myocardial infarctions or previous bypasses or angioplasties, I do prefer to do stress echocardiograms because it's important to differentiate from the baseline. ECG would be in that situation very commonly defective. And very commonly such thing arises when we talk about women because they are known to have some, especially in V1, V2, and V3, some T-wave inversions and echocardiographic changes. So the next step is when we do a stress echocardiogram, what do we do? The first is select the type of exercise. You look at the patient, whether the person can walk on the treadmill or the person is immobile in such a sense that walking on treadmill can make the person hurt. So in that situation, supine bicycle ergometer, if the person can still exercise, or upright bicycle ergometer can be chosen. If the person is not mobile at all, then dobutamine test is important, specifically when we have to do pre-operative assessment of risk of operative precipitation of ischemic heart disease. Then we do the choice of induction of stress by various mechanisms that I discussed about. We have to monitor the responses and specifically acquire the echocardiogram. The stress test could be either abnormal, completely normal. That means when the person exercises, the heart rate increases, the left ventricular size reduces in size, and also the ejection fraction improves, and there is no wall motion abnormalities which arise, which were not there at the baseline. On the other hand, if the person has multiple coronary artery disease, sometimes it can so happen that all the areas become hypokinetic on exercise. And in the result of that, the ventricle may be dilated and the ejection fraction may be dropping. On the other hand, if we have single vessel disease, one of the territories could be becoming dysfunctional and the rest of them may not be. So the other thing which I would like to say is it all depends upon the ischemic cascade as was described in the first thing. For example, if the LAD lesion is there, the subtending area of the LAD would become dysfunctional. The first thing would be flow heterogeneity, which the perfusion scans can pick up at times. Metabolic alterations would come in CS sampling, PET scans. Left ventricular filling changes would be appearing next, and then comes the wall motion abnormalities, which is the hallmark of ischemia on stress testing. This was described, the 16 or 17 segment scoring system by Dr. Sunil in detail, and I'm not going to go into detail about it. But this figure I like very much because this, in a bullseye plot, gives you a kind of a distribution of anatomical coronary artery disease. The LAD runs in anterior interventricular group, wipes down the apex, and so supplies all the areas around it, almost supplying 55% myocardium, anterior and anterior septum. The lateral wall, because the circumflex runs in AV group supplying the OMs, so the lateral and posterior wall is supplied by the circumflex territory, and the PDA supplies the basal and mid septum, and PLBs usually, in case it is dominant, it is supplied by the RC territory. So this is the usual geometrical distribution, and we should hold it in mind to distinguish single to multiple vessel disease when we are assessing wall motion abnormalities. A word about supine bicycle ergometer, which is important now because of the fact that we can do throughout the procedure echocardiogram and assess the volumes. And the guidelines say that there are various phases. First is the rest, then we increase the exercise duration till the time the person is able to tolerate, or we allow the person to stop. The reasons for stopping are obviously if the person has intolerable symptoms, if the person has muscular exhaustion, if the person has severe hypertension or hypotension or significant arrhythmias. All of the reasons are there to stop the exercise and do the post-exercise assessment. The assessment is done again in the left ventricular systolic function, regional wall motion abnormalities. We should look at the diastolic function, emergence of MR or worsening of MR, and pulmonary arterial pressures as well as right ventricular function. This is the completeness of our assessment of stress echocardiogram, hemodynamics as well as wall motion abnormalities. I start with this classical case, 72 years old gentleman, diabetic hypertensive, had a previous angioplasty. So obviously there was a concern. Whenever we are starting with the stress echocardiogram, in this particular case, we did a treadmill exercise testing. We would require all the 4 views to be drawn, and all these things are then cataloged into a particular frame. The 4-chamber view, which shows us the basal, mid, and apical septum, basal, mid, and apical lateral view. Then we look at the 2-chamber view, where we look at the basal, mid, and apical inferior, and basal, mid, and apical anterior wall. The 3-chamber view, where we will look at basal and mid posterior and basal and mid anterior septum. And then we also, as Dr. Sunil was mentioning, confirm these findings in various other things at the level of mitral valve, short axis, papillary muscle, and apex, and make sure that we are not missing the board. Today, we have strain rate imaging. Dr. Sunil was mentioning about it, and this, in most of our centers, higher end centers, we always look at strain rate imaging because this segment-wise can give us the wall motion abnormalities, the ejection fractions, segmental ejection fractions, and it's a single frame, very easy to assess. So then the second important thing is whenever we do a comparison, the machines today actually break the whole systole into equal fragments and compare the baseline to exercise-induced wall motion abnormalities. We have to start looking at segment to segment, basal septum to basal septum, mid septum to mid septum, apical septum to apical septum, and then only we can compare whether the segments are improving or not. For example, in this particular patient, the basal inferior was scarred, and here it was showing a little improvement. This means this is a normal response. For example, this particular patient, this is a 4-chamber view. But if you look at the 4-chamber view, the contractility at low dose has been better. But at peak dose, after recovery, there was a dilatation. So this is a late sign of inducible ischemia, probably a global ventricular dysfunction. The other thing is we always look at the diastolic filling patterns, because sometimes, as I said, the initiation of the increased filling pressure appears in the form of diastolic dysfunction. E to A ratios change, and also the systolic PA pressures also increase. In this particular patient, the pressure gradient was 48. That means the PA systolic pressure had increased to almost 58 millimeters of mercury after exercise, which is a sign of diastolic dysfunction emanating from heart failure. A word about pharmacological stress testing. So for the first thing, we have to obviously choose the patient rightly. And in this particular patient who cannot be mobilized, pre-operative assessment or whatever, we put an IV line first, electrodes, and make sure the person is in an ambient environment and well taken care of. The resting assessment is done again by echocardiographic images, as we have already discussed, the 3, 2, 4 chamber images and the 5 chamber images. The dobutamine is then started in a low dose, 5 microgram per kg per minute. And after every 3 minutes, we keep on increasing 5 to 10, 10 to 20, and then 20 to 40. Sometimes atropine injection is required after the 20 micrograms has failed to increase the heart rate. Subsequently, we can give 0.3 milligrams of atropine injection because in cases of vagotonia, it releases the vagotonia and increases the heart rate response. And then we keep on monitoring the ejection fraction and wall motion abnormalities. So for a particular segment in dobutamine stress echocardiogram, when we do so, there could be various possibilities. A normally contractile segment improves the contractility from 30% contractility to 50% contractility. And this means a normal segment becomes hyperkinetic at peak dose, and this is a normal response. There could be another possibility that a normal contractility segment, when we give low dose, it improves or remains static. But when we give peak dose, when the heart rate goes up very high, it drops the contractility. And this is called as ischemic response. That means when the heart rate has increased, the ischemia has set in, and this is worsened. That means normokinetic becomes hypokinetic or akinetic. On the other hand, there is a possibility, and probably the next speaker is going to talk about it in detail, when the hypokinetic segment or akinetic segment at rest, we give low dose dobutamine, the contractility actually improves. Hypokinetic becomes normokinetic, or akinetic becomes either normokinetic or hypokinetic. This segment then, when we give peak dose, increase the dose of dobutamine and make the heart rate go high, this drops the contractility further and becomes again akinetic or hypokinetic. So this is biphasic. That means the segment improves and then deteriorates again. And this is a sign of hibernation or alive myocardium. In the dead situation, when the myocardium is dead, do whatever you may, the contractility would not improve with any kind of dobutamine. So this is something which is so very important. And as I said, today, if done rightly, the accuracy of dobutamine stress echocardiogram and stress echocardiogram is very high. I quote here the data from Everest trial. This is a UK-based 31 hospitals trial. Too good to be true, but 95% sensitivity and 96% specificity. I think it is all important to understand that every patient has to be taken into consideration. Mind it, what was done in this particular study was 68% patients had inclusion of contrast echocardiogram. Mind it, Dr. Sunil did mention of the contrast because it improves the delineation of the endocardium so beautifully that the margin of error reduces. Also, it gives perfusion imaging possibility, increases the outcome of stress echocardiogram. Dobutamine stress echo was done in almost 2/3 or more than 2/3 of the patient. Exercise stress echo was done in 1/4 of the patient. And pacemaker induced, when the pacemaker is there, sometimes you can increase the pacemaker rate and cause the stress testing artificially. But this is important that if you do it right, it is very important. Lastly, the prognostic value is important. If a person has a normal stress test, then the chances of that person having some cardiovascular event in 4 to 5 year is less than 1% per year. So that is something which is a surety. That's why it's very good. The positive test means that the risk of a perioperative mortality can go up to 10 to 30%. So that is why it can be a predictive model, and we can actually explain better, be ready for perioperative complications much higher in such a situation. And this is a very important slide here. The risk of death in MI, if we talk about, the stress echocardiogram is much better as compared to if we just look at the clinical setting or exercise TMT alone. On the other hand, if you look at the death, MI and unstable angina precipitation, then also the stress echocardiogram is much better as compared to that. There are a lot of new things which are coming up. One, the routine involvement of strain rate imaging, which helps the novice user, and the ambiguity about certain segmental wall motion abnormalities, it is much better. The contrast echocardiogram, as I said, in the Western world is being very commonly used. In our country also, many centers are using it. We are not using it. It unnecessarily increases the cost. But contrast echo has both the uses: myocardial enhancement, myocardial contrast imaging, as well as contrast delineation of the endocardial borders. And nowadays, we also has automated analysis. So a lot of new things are happening in 3D imaging and all. And ladies and gentlemen, to conclude, I would say that stress echocardiogram provides a detailed evaluation of cardiac structure as well as pathology and functions in ischemic heart disease, very high sensitivity and specificity. And if done rightly, it can be almost certain to give the right answer. Today, we are all talking about AI-assisted stress echo implementation cycle, where the AI actually analyzes the stress echocardiograms, give us a direction where the analysis is then interpreted by the healthcare professionals. This increases the diagnostic capacity and also helps in advancements of the knowledge in the future. Thank you. Thank you for your attention.
Thank you so much, Dr. Mittal. Very comprehensive talk. Thank you so much. Couple of questions. So what is your usual dobutamine protocol endpoint?
So my usual dobutamine stress echo endpoint is, again, the two things, as I said, either the symptom mimetic, if the person has symptoms. Otherwise, I usually cut it at 85% of my age-related maximum heart rate. So that is something which I have to, because if I achieve 85%, then majority of time, those data sets which I've discussed come true.
Perfect. When do you consider switching from dobutamine to exercise or vasodilator stress?
Okay. So dobutamine, as I said, is something which I mean, against what was there in the UK Everest trial, I usually prefer to do upright exercise technologies because this is more physiological and contributes to the muscular involvement as well. Dobutamine I reserve for people who cannot walk, too elderly, too frail, locomotive problems, and things like that, especially perioperative assessment when the person cannot walk. Otherwise, I usually prefer to do an upright exercise. If the person cannot stably walk, then probably having good knees, I would make that person cycle rather than do treadmill one. So those are the decision makers. The decision has to be before we start the test rather than after the stress. We cannot swap to exercise. The decision is made before we choose the particular stress test.
Correct. So how do you approach discordant findings between stress echo and angiogram?
So this is a wonderful question. You know, this is not that I would say that angiogram is a gold standard. Angiography is a gold standard only for epicardial vessels, not for microvascular circulations and all. So many a times what happens is when we talk about macrovascular disease, we actually, if we interpret the stress echo images correctly and use the strain rate imaging and the regional wall functions adequately, the chances of us predicting right answer and correlating well with the epicardial coronary artery is very good. We must understand that microvascular disease, specifically in ladies and some other sets, can be there, which produces diastolic dysfunction and sometimes even LV systolic dysfunction without them having epicardial coronary artery disease. So I would say, I would believe the stress echocardiogram, because today, if we look at, there is a beautiful paper in circulation which says that almost 2/3 of the people who have ischemic heart disease do not just have epicardial coronary artery disease. They have multiple sources of ischemia. I mean, microvascular as well as spasmodic reasons for ischemia. So that is something which we have to be weighing the pros and cons for.
Great. Last one. How much space gap is you should keep between a treadmill and an echo machine?
Okay, so I would say that the treadmill and the echo machine is something which I always interpose between the bed. I think what is important is that the stress echocardiogram machine and the treadmill machine should be at least a bed's width apart.
Perfect. That's great. Thank you so much, Dr. Mittal, for a nice talk. Let's go ahead. If I can request Dr. Aniruddha Dey to start sharing his slides, please. He's going to speak on myocardial viability. Visible, yes.
Well, visible?
Yes, please, go ahead.
Thank you, Santanu, and thanks to Glenmark for giving me the opportunity to say about the viability by myocardial viability by echocardiography. In fact, my three previous speakers have done a wonderful job. So I have nothing new to say, but still I'll try to do my justice. See, myocardial assessment, viability assessment, is applied to the myocardium with a potentially reversible contractile dysfunction in patient with the coronary artery disease. It can be divided into stunned myocardium and hibernating myocardium. They're not moving. Of course, it is most important is the stunned myocardium. What is that? Is a prolonged contractile dysfunction after a transient ischemic episode and coronary reperfusion. This automatically recovers over a period of time. Stunned myocardium is commonly noted after thrombolysis and primary PCI. Whereas in the hibernating myocardium has reduced contractile function due to the persistently impaired coronary blood flow. Hibernating myocardium regains contractile function only after partially or completely revascularization. And the goal of myocardial viability assessment is to identify these patients who will improve with coronary revascularization. Why it is important? Because it is useful to try those with heart failure into ones which require revascularization versus those who require left ventricular access devices or cardiac transplantation. Because if there is a no viable myocardium and if do revascularize, that can do worse than good. It can predict the recovery of myocardial function with treatment and thus the prognosis. So assessment of myocardial contractile reserve can be done by echocardiography and other imaging modalities also. So in a nutshell, what is the stunned myocardium is that in acute ischemia, there is a decreased perfusion, decreased function, but after relief of ischemia, there will be restored perfusion, but still there is a decreased perfusion. Of course, there is a viable myocardium. Whereas in hibernating myocardium, there is a decreased perfusion, decreased function, and of course, here is again the viable myocardium, which can only improve after revascularization. Metabolism of myocardial cells are assessed best by position PETs, whereas the myocardial scar, dead myocardium, can be detected best by CMR by what we call it lead gadolinium enhancement or LGE, And of course, it can be done by the multi-detector computed tomography. But here, I will concentrate only on the echocardiography, and for which there are certain parameters. First and most important parameter is diastolic wall thickness, will give an idea regarding the myocardial viability. Thin and hyperdense myocardium is likely to be scarred and non-viable. Second is the dobutamine-Strauss echocardiography, which Dr. Mittal has rightly said. I will touch upon it a little bit about it. Third is the myocardial perfusion is assessed by the myocardial contrast echocardiography in SORI called MCE. And fourth is the strain and strain rate imaging is done by the tissue Doppler and the speckle tracking. And there are various methods of assisting diastolic dysfunction using Doppler and the tissue Doppler echocardiography. End-diastolic wall thickness is one of the simplest methods to screen for myocardial viability, which cardiac surgeons often very fond of. If it is a more than 5.5 millimeter, has a sensitivity of 94%, a bit with a low specificity of near about 50% for detection of the myocardial viability. But if it is less than 5 millimeter, then there is a less than 5% will be viable, while with thickness above that, viability is more than 50%. So here is an example you can see. This anterior ventricular wall is to entire extent is totally thinned out and kinetic. And if you measure it, is only 4 millimeter. So this is an example where you can, if you zoomed it in another view, it is only 4.2 millimeter, same thing. And so this myocardium is likely to be, not likely to be viable. Again, the same thing in the different view. Same patient in the different view. In contrast, see this patient in the inferior wall. There might be some contraction available, some viability is there, maybe some partial thickness scar is there, and would measure is that is about 5.8 millimeters. So it's in the borderline. Here we have to assess the viability in this case. We cannot outright reject this one. We cannot outright reject this one. And the second important that already Dr. Mittal has covered, that, but few things I must mention, that pharmacological stress echocardiography can done using the dobutamine, adenosine or dipyridamole. We are mainly practicing in our hospital in the dobutamine stress echocardiography, where the low dose dobutamine echocardiography is useful in assessing the myocardial contractilism. We do the parasternal and the apical views of 16 to 17 myocardial segment. Higher dose of dobutamine can be used to check whether there is any biphasic response indicating the ischemic viable myocardium. There is the myocardium which are ischemic but still viable. The response to dobutamine can be divided into 4 types that I already enumerated. But to summarize it in monophasic or sustained response, what is that? A low dose dobutamine increase the contraction, which is further enhanced in high dose. That is, you can see the monophasic response. In the low dose, it increases, and even in the higher dose, it go on increasing the dose. So that is called monophasic response. And the same thing, another is another monophasic response. Then is the biphasic response. Biphasic is in what? The low dose enhances contraction while the higher dose decreases the contraction. That means ischemic viable myocardium. Another time is called ischemic response, in which the both low dose and the high dose produce decrease in contraction. And last is the non-phasic response, where there is hardly any contraction of the segment throughout the cycle. So here is the biphasic response. You see the epicoseptal wall. This is the basal one. Here there is an increase in the low dose, but again come back to the high dose, it is in the back to the resting position, and that in the post-recovery phase. Same thing to the, you see the baseline inferior wall, low dose, improvement of the mid and apical inferior segment, from here to here, but that again back to the previous conditions, and that in the recovery. But in addition to this, in peak dose, you can say worsening of the wall motion in this segment. Here, this can be depicted by beautifully by if you do the digital subtraction image, biphasic response. What is that? You see the anteroseptal wall is the white is the systole and the back is the early diastole. So look at this. There's no white, but here you can see the good white, but here you can come back to same thing, and same thing in the recovery phase. Same thing in the inferior wall. You can say the inferolateral wall is the same. If there is no white, again there is a white, and same thing is back to normal, and then the same thing. So you can use this there. And what is that? Ischemic response. Ischemia in both low and high doses dobutamine for viable. The mid and apical segment have reduced thickening, and there is a 90% stenosis with the mild ARD. There is no change between the low dose and high dose. Of course, there is the importance of particularly the if you want to see the RWMA. This is a patient with a very poor window. There is no contrast, myocardial contrast has been, you hardly identify anything. But if you give the dobutamine in the resting pages, see, there is a RWMN in the distal septal and the apical region. And it extends to the mid-inferoseptal, it increases to the mid-inferoseptal and the distal lateral segment, and also the distal lateral segment to the, if you do the stress echo. And last is the non-phasic response, inferior posterior wall. What is there? If you give the low dose, high dose, whatever, there will be no changes. That is only a scar. So roughly 40% will have a non-phasic response, while nearly 1/3 can have a biphasic response. Sustained response may be noted in nearly 1/5, and worsening may be noted in 15%. By far, the biphasic response had the highest predictive value for recovery of function after coronary angioplasty. Non-phasic and the monophasic response predicted poor recovery of function, while the ischemic response was in between. Dobutamine stress echocardiography has been noted to have better specificity than nuclear imaging and is a fair value of prognostication as well. Echo-based technique for assessment of the myocardial viability has a certain advantage as well as certain limitation, of course, is there. What is the advantage? Because techniques are safe and do not have the risk of ionized radiation like nuclear perfusion studies or the PET. Due to the portability of echocardiographic equipment, even bedside evaluation is possible and the equipment are widely available. Cost of procedure is not much. Unlike CMR, presence of pacemaker or defibrillator not a problem. Other coexisting, very, very important is that other coexisting cardiac pathology can also be assessed by echocardiography at the same time. And there is a good relation between the echocardiographic finding and the outcome of the revascularization. What are the limitations? The both image acquisition and interpretation of image are operator dependent, and there could be significant interoperable viability. Spatial resolution of echocardiography is something relatively low compared to the other modalities. Poor echo window is another important, but that can be circumvented by the use of the myocardial contrast agent. So that can, if you use it, the myocardial contrast agent, then specificity sensitivity is very high, what Dr. Mittal has already told. Myocardial contrast echocardiogram has been used in the assessment of myocardial viability. And downside of the myocardial contrast echocardiogram is the cost of ultrasound contrast agent. Intravenous administration improve the visualization of the myocardial segment and enhancement also in addition the perfusion studies. So there are various studies you can say the study with the perfusion imaging with the myocardial contrast is far more superior compared to the other modalities. There are a lot of studies were there. And I'll skip this slide, but I'll go to the see this side. The normal perfusion at rest, but delayed perfusion at the stress. What happens? You can see the pre-high MI flush. Rest is immediately filled up, immediately plus. You can see some lagging, but within 1 second it filled up. But 2 seconds it is absolutely filled up, and 4 seconds is again same. But if you use the stress, it should be filled up within 1 or 2 seconds. But here you can see immediate post plus, there is a lag behind of the perfusion. There is no contrast agent seen in the myocardium. Hardly few contrast agent, even 1 second. Even at the end of the 4th second, there is still lagging. There is a lot of contrast to be accumulated. So there is a definitely delayed perfusion in the stress. And you can see same thing in the same EO, and if you do the sign, there is in the lateral wall is you can see the significant circumference marginal lesions. Same thing you can see both rest and intermediate stress. Same thing here also in the you can see there's a lot of lagging behind during the stress. There's a lot of lagging. There's a lot of less contrast you can see in the rhythm. So myocard now is the very important chapter, is the myocardial strain. You can do the viability by myocardial strain. How? Myocardial strain is the measure of deformation that I already know myocardial segment related to the initial length and that to the strain rate. This is in effect the gradient between the velocities of 2 points. Strain and strain rate can be measured using the tissue Doppler and the Pickel tucking. We know. What we'll get it? A change in radial myocardial strain of more than 9.5% has been shown to have a sensitivity of 84%, near about 85, more than 80% for detection of the myocardial viability. And change in longitudinal myocardial strain, that is GLS, more than 14.6%, roughly 15% had a sensitivity of near about 90% for specificity and sensitivity for detection of the myocardial viability. So low dose dobutamine infusion along with the strain rate assessment is useful to assess the myocardial viability. What happens? Increase in the peak systolic strain rate of more than 0.23 per second give a sensitivity of near about 85% compared to the PET as a gold standard for the detection of the myocardial viability. So it's a very good thing. Thus, increase in the peak systolic strain rate during low dose dobutamine infusion permit discrimination between the viable and the non-viable myocardial segment. Here is a very good example you can say these days. One patient with the baseline is a patient of the RCA lesion. CTO RCA has been before performing the PCI. You can see the GLS of 17.3%. And equal the regional longitudinal for RCA area, you can see the 12.6%. 6 months after CTO PCI, the GLS increased to 21%, whereas the regional longitudinal strains also increased to 16.6%. And this patient was subject to the low dose dobutamine. What will happen? In low dose eating, GLS further increased to 22.2%. And regional longitudinal also increased to 16.7 to 24%. But in the peak dose, you can see GLS again come down to 99%. Particularly in the RLS area regional, it come to 12.6, that is back to baseline level. So there is still the flow limiting CAD is there. Here I finish with a last example, is a case of acute anterior wall myocardial infarction. You can say it seems to be that is absolutely non-viable myocardium, but there is a chance of little contraction is there because the thickness is near about the 5.5 to 5.8 millimeter. And this patient of acute MI of 72 hours duration with associated COPD presented with a severe hypotension and metabolic acidosis, blood pressure on very hypotension on inotrope, and this patient ultimately developed into respiratory failure. Some ventilative support is there, and LAD shows critical stenosis. Now, what is the specific perfusion modality in this patient? Option for myocardial viability in this ICU ventilated patient essentially non-existent. MRI of stress dobutamine. MRI is not practically feasible. Transesophageal non-diagnostic. Other non-contrast echocardiography. No, there is incremental value. Here, MC is the only option. So if did the MC in this perfusion in this anteroseptal wall, you can see the anteroseptal wall is very lagging behind after the flash. Same thing, anterior wall, septal wall is very lagging behind after the flash. And this can be better appreciated in the zoom view. You say, look at the after flash, is hardly any contrast available in the anteroseptal wall, in spite of giving 10, 15 seconds. But still, some contrast you can see. Some contrast is even after 10 seconds. So there is a delayed appearance of the myocardial contrast. So if the perfusion is there, so some viable myocardium is there because the contrast is reaching at the microvascular circulation. And if you do the parametric imaging, you can see the red one is dead, but still there is some green one is perfect. So that's conclude my lecture. Thank you.
Thank you so much, Dr. Aniruddha. Let's see some questions. We have my specs. Okay. How do you integrate wall thickness, contractility, and perfusion in a single report?
Well, that can be done very easily, no problem. See, I have shown this. You go segment by segment. There is 17 segment. What are the thickening of the wall? You can see is no problem. And then in the resting stage, in the low dose dobutamine stage, in the peak dose dobutamine stage, and ultimately in the recovery page. And you do the strain imaging along with that. That will give a very comprehensive idea about the viability of the particular patient, whatever you want.
Correct. So yeah, I mean, this question, what is the role of strain imaging in differentially viable versus not? You have already.
So that is already been covered by the.
So what is the added value of contrast perfusion imaging in viability assessment?
Oh, that side showed you. In the whole of the slide, there is a. If you do the contrast image, see, in a very poor window, even in a good window, if you do the contrast, give the contrast, that will give a very clear endocardial delineation. Even if the minutest hypokinetic changes can be assessed if you give the contrast reading, both in rest and particularly during the stage when the heart rate is very high. Even in fact, that time strain imaging may be like fallacious, but your contrast agent and looking at the wall motion abnormality during the stress by giving the contrast agent. That's why Dr. Mittal has said the specificity and sensitivity with after the contrast agent is practically almost 95% is the gold standard of the, it is comparable to the PET scan.
Great. So I think I have one question for to all the panelists, to all the speakers. Is Dr. Mittal there? Can I also have Dr. Allegation and Dr. Bohra? Yeah. So I mean, Dr. Aridhya rightly suggested that we can do a strain imaging in exercise and contrast, but the task force of strain imaging says that the values of strains are not valid at a heart rate more than 120. So, your thoughts?
Yeah, my one comment. That's why they are telling this a low dose dobutamine is very, very important. While doing the strain imaging, there your heart rate may be around 100 to 110 or even less than that. If this patient is having a resting heart rate of about 70 per minute, so if you increase by about 30%, so go to the 90 to 100 even heart rate, that will give you a very good idea. But don't go to that is the 85% of the heart rate of the age matched higher heart rate. So like about 140 or 160 like that, then strain imaging is very, very difficult. In fact, whether it is validated is not, that is the issue. But it is very difficult to perform. The person who are like you and everybody who are doing is, that is a difficult task, particularly in the heart rate of 140 to 60. There's a lot of fallacy might come.
Yeah. Dr. Mittal,
a lot of artifact will come.
Yeah. Your thoughts, Dr. Mittal?
So that is absolutely well taken. You know, whenever there is heart rate which is very high, we have to be very cautious not to over assess this thing. But what is important is just like dobutamine stress echocardiogram, I very frequently use supine bicycle ergometer, where I do the imaging at various stages of the supine virus, because the person is almost half lying and we can do the imaging. And in that situation also, the wall motion abnormalities as well as strain, I do at least a heart rate of 100, 110-ish. Yes, whenever the heart rate goes up, I don't say I will not do it, but with a pinch of salt. There are certain glaring conditions where the strain actually has picked up subtle apical segment abnormalities where we had ranked them as completely normal. And these are situations when you actually don't, you can just put a question mark of suspicion and do a confirmatory diagnosis.
Great. So I think
Dr. Santanu, one thing.
Please.
Santanu, is that how many there's a question to everybody, how many are doing the supine bicycle ergometry in compared to the stress dobutamine echo? Because in our hospital, in the Apollo in Kolkata, there's no supine ergometry is there.
It's an
We all
expensive,
do this
it's an
dobutamine
expensive
stress.
thing. Yeah, I agree. It's supine bicycle is an expensive machine. It has its own, but it has its own advantages. I think.
Yeah, that I agree.
So I think that's valid. Dr. Alagation, your thoughts, please.
One thing that is, even if the heart rate is very high at the end of the stress test, whatever, even if it is a treadmill test or dobutamine stress, wait for the heart rate to come down to 100 or 90. The wall motion abnormalities sometimes persist. And also, especially the strain abnormalities don't go away that fast. You may be able to detect the strain abnormalities even after 1 or 2 minutes when the heart rate comes down to 100 or 90. At that time, it will be very useful to do the the strain echo.
Yes, sir, absolutely correct. Because this is the physiology used in the diastolic stress test, particularly in the same physiology.
Perfect. I think we have had a great discussion. I was told that we have as much as 1,450 delegates live. Great. That's congratulations to all the speakers and thank you so much. Over to you, Mansi, please.
Yeah, sir, I would like to project the poll questions. So after each session, we have conducted a few poll questions. So this is the first question. My slides are visible, right? Yes. So what is the minimum end diastolic wall thickness you consider as a viable? So approximately 30% audience, they have voted for the 6 millimeter. Next question is, what is the most common mechanical complications of STEMI you encountered in your clinical practice? So almost 60% they voted for, obviously, the papillary muscle rupture is the most common complication they found. Third question was on, what is your preferred stress modality in your clinical practice? So dobutamine and vasodilator, these two options got the equal votage, 36 and 37%. And in patient with akinetic wall segment, would viability change your revascularization strategy? So almost more than 50% audience, they voted for the yes. They would like to change their treatment strategy. So these were the poll questions.
Great.
So I'm requesting you for the closing remark.
So I think we had a good discussion, a very comprehensive and a detailed discussion on an important topic of ischemic heart disease and imaging by an echo. We will surely meet next month for another session. Over to you, Dr. Mansi, for your concluding remarks.
I think this is an opportunity to thank Dr. Sengupta sir and all the speakers whose expert guidance in depth knowledge and patient teaching made this session very insightful and practical. So we hope this training has not only enhanced our technical skill, but also deepened our clinical understanding of 2D echo. So I'm requesting my marketing and sales colleague, Mr. Akash Asti, for vote of thanks. Over to Mr. Akash.
Thanks, Dr. Mansi, and thanks to all eminent panelists as well as speakers. So on behalf of Glenmark, myself, Akash Asati, I'm the business head for the Zesta division. Extend our heartfelt thanks to each one of you for joining us in today's insightful session on the BEAT Basics, which is basically advanced 2D echo techniques. This enriching initiative is carefully tailored and crafted by the esteemed Dr. Nitin Burkle, Dr. Shantanu Sengupta sir, and Dr. Manish Bansal sir. With expert guidance from eminent faculty members, Dr. Sunil Bohra, Dr. Alga Sen, Dr. Sanjay Mittal sir, and Dr. Andrew Day sir, I thank each faculty member for this knowledgeable session. We hope the clinical perspective shared today will add value to your practice and deepen your understanding. All active participation from all the attendees is what makes this platform meaningful, and we'll look forward to welcoming you again next month in our upcoming session for this impactful series. Thank you once again.
Have
a great week ahead.
Thank you, sir.
Thank you, everybody.
Thank you, everyone.
Thank you. Bye.
Bye.
Thank you.
Thank you all. Yes.